I want to thank you again for your patience. I know that we have fallen behind, but I think we can all agree that it has really been worthwhile, even though we're a little bit behind schedule. All of our presenters have really brought dimension to this conference that we've not had before. And so we're so very, very grateful for everyone. I have the pleasure of introducing Ms. Jasmine Lee Hill, and she is a nursing practice consultant, a nursing directorate at McGill University Health Center in Canada. Thank you for coming to be with us. We are so blessed with people from outside the United States. A little bit about Jasmine. She is a graduate of the University of Ottawa with a Bachelor's of Science in Nursing and a Master's of Science in Tertiary Nursing Care. She also has her Lean Six Sigma Green Belt since 2022, as well as a certification in Med-Surg Nursing since 2018. She has 17 years of experience in the healthcare system and has served in various roles. Just lost my thought, sorry. During her years as advanced practice nurse, she has continued to create multiple surgical protocols and processes, including the care of tracheostomy and laryngectomy patients. She is also a reflective, we just talked about reflection, a reflective practice facilitator, and sits on multiple committees such as the Clinical Practice Review Committee, Nursing Research, Nursing Awards of Excellence, and the Psychosocial Peer Support Program, as well as the Canadian Association of Medical Surgical Nurses as an executive member. Please help me welcome Jasmine.
Good afternoon, everyone. Thank you so much for giving me the opportunity. So I won't really introduce myself too much, but I'm Jasmine. I just give you a bit of background, actually. I've been a nurse actually for 18 years now. A lot of it was in med surg, and it was funny that you said you don't like trachs, but actually that was my go-to. I did a lot of dossiers with the tracheostomy and laryngectomy population. For 5 years, I was a bedside nurse on a surgical unit, and I got a lot of my experience from there. I had a wonderful nurse manager who gave me an opportunity to work on a particular project, which kind of led me down this career pathway. So I'm forever grateful to him. After that, I was an advanced practice nurse, so more like a clinical nurse specialist, for 11 years. We can't use clinical nurse specialists in Quebec anymore, but we're still fighting for that title. So we call ourselves advanced practice nurses. And I've spent the last 2 years as a nursing practice consultant for the nursing directorate. So today I'm going to talk about our project we did, which is optimizing the delivery of nursing care, and we did a time and motion study. Just the outline, we're going to go over some of the context and some objectives, how we decided to conduct this project, what were the results, and what were our strategies. So to give you a bit of context, the McGill University Health Center is a large institution. Although when I look down the street and I see the Southwestern facility, I'm kind of contemplating what my definition is of large institution. We are a public healthcare system, so we have universal healthcare, so it's free healthcare for all. We have 5 sites that are included in our healthcare center. So we have the Children's Hospital, we have a neurological hospital, we have a Montreal General Hospital, which is a level 1 trauma center. We have the Royal Victoria Hospital, which does a lot of the oncology procedures. And we also have the Lachine Hospital, which specializes in long-term care for ventilated patients. So we are 5 hospital sites. We have 17,000 employees. And annually, we manage over 34,000 admissions, 28,000 surgeries, 160,000 emergency room visits, and 540,000 outpatient visits. So why we decided to embark on this project, we had a lot of bed closures. 59 out of the 947 beds that we had were actually closed, and the majority of that was due to staff shortage. We had an overtime rate of 5.86%. We had much lower recruitment and retention rates that we were noticing. So in addition, also, we had 24% of our nursing staff that had less than 2 years of experience. And our retention rate of the new hires at 1 year was at 77.9% when our targeted goal was supposed to be at 85%. We had a lot of operational challenges. And of course, the nursing shortage, which I think is worldwide. The MUHC, we had targeted to hire 850 nurses in the year 23 to 24. However, our organization projected to only hire 350 to 400 out of that 850. So everyone is fighting for the same pool of nurses. And this is why we felt it was really crucial to start looking towards optimizing the nurses that we have now and how to optimize their current workflow and their processes to help reduce their workload, improve their work satisfaction, and ultimately provide better care for our patients. So our main objective was really to optimize the delivery of care of nursing by decreasing their workload, by giving them back 5 to 10% of their time to perform more value-added care, value-added activities within the scope of their practice. So we do a lot of 12-hour shifts in our institution. So if you're looking at a 12-hour shift, we wanted to give them back at least 30 minutes to an hour of their time in their shift, so they're able to perform more direct patient care and more value-added care. We really wanted to change their environment and their work processes to allow them to work more to the full scope of their practice and allow them the time to be able to do this. Previously, we mentioned we didn't have time. There's a lot of competing priorities. I think that was mentioned in one of the presentations yesterday, actually. So we wanted to find that time for them to allow them to do that. And another key component is to ensure they know the full scope of practice. So, with this added time they're supposed to get back, we don't want them just sitting at the desk doing nothing. We want them actually to working to their full scope of practice. And that's something I think we need to improve upon just in our setting. And I think you made me reflect on that actually the other day, is we want to really ensure that they understand what working to the full scope of the practice really means. So we decided to do this in two pieces. We conducted a survey, which is the actual scope of nursing practice survey. So the scope of practice, I don't remember the term you used yesterday, but some of my terms are probably different because they're Canadian. But the scope of practices refers to the range of duties and responsibilities legally entrusted for which nurses have the training, knowledge, and skills. And the actual scope of nursing practice defines the actual scope or the actual practice that the nurses believe they are doing. So we should be working to the full scope, but when we do the survey, this is what they think they're actually performing right now. So we conducted that survey and as well as a time and motion study. And that aim was to really identify the daily activities that were being performed and the times that was spent engaging in these activities by nurses, by our licensed practical nurses, so our LPNs, and by our patient care attendants. We wanted to identify the activities that were also non or low value added, and we wanted to identify potential areas of improvement. So we decided to do this on 3 different units. So the first one was the Montreal Neurological Hospital. It's a 25-bed unit. It's a neurosurgery and neurological unit. The second one was the General Hospital, where we have our trauma, TBI, orthopedics, and it's a 30-bed unit. And the final one was still at the Montreal General Hospital, where we have our thoracic surgical unit, and it was a 17-bed unit. And the results I'm presenting you today is really the cumulative results of all these 3 areas. So the actual scope of nursing practice, the survey results. So this is based on a Likert scale. So 0 being never, meaning they don't perform that. 5 being always, like they always are able to perform this for their patients. And you can see the dimensions or the categories listed below. And this is actually developed by Derry, or Derry had published this article. So nurses felt they were only often able to do an assessment and create a care plan for their patients. They felt they were only often able to do teaching for their patients and families. Again, only often able to communicate and care coordinate, which really refers to ensuring continuity of care within the interprofessional team. And they only felt they were only often able to, provide knowledge updating and utilization, which really means keeping their own knowledge up to date, improve their own practice, and also share that knowledge with other people. In addition, the nurses only felt they were sometimes able to integrate and supervise staff, and were only sometimes able to ensure quality of care and patient safety, which is a little scary, which refers to getting involved in updating practices and improve quality, report deficiencies in quality and safety of care. So they only felt they were sometimes able to do this. So we kind of found this quite alarming because we should really be on the spectrum of always, or at least almost always to always. So this kind of highlighted a lot of issues for us that we wanted to work on. So those were the study results. For the time and motion study, these were some of the methods we used. So we did it across the 3 hospital sites, like I mentioned. Participation was voluntary. And basically what we did is we had a group of data collectors go in and shadow nurses or LPNs or PABs. Sorry, I call them PABs. It's patient care attendants in English, one-on-one during their shift. All these data collectors were nurses, which I thought was super important because there was a previous study by another institution that had someone from HR come and shadow the nurses, and they just were not able to capture what the nurses were doing or didn't fully understand what the nurses were doing. So it was really important for us to have our data collectors be nurses or who were already practiced as nurses. They also received, so the data collectors received a 2-hour training, theory training, and a 4-hour inter-observer reliability assessment to ensure that we were all taking accurate and reliable data collection. So basically, what I saw, the next data collector would also see the same thing, but we also did a lot of data cleanup where we could recategorize things to make sure we were all saying the same stuff. So we did this for 34 days. It included 8 to 12-hour shifts. We observed 226 hours of nursing time. This excluded permitted breaks and short transition time. So if they were just walking from the patient room to the medication room, we just kind of omitted that. We had 16 nurses participate. 6 of them worked in a dyad. I don't know if you guys have dyads here. Yeah, with the LPN. So a nurse would be paired up with an LPN. And we had 3 externs. So these are nurses coming from school that have kind of an externship for the summer. We observed 7 LPNs, 5 patient care attendants, 2 assistant nurse managers, and 1 coordinator. But just to note, the assistant nurse manager and the coordinator, we did exclude from the results section. Otherwise, the presentation would have run on very long. So when we were collecting the data, so we basically had a little tablet. Oh, I didn't mention, can I go back? Back up. So the TimeCat, so there's no conflict of interest. I'm not selling this TimeCat tool. It's free on the internet though. You get 5 free sessions unless they've changed that. And basically this is how you capture your data. So you would plug in everything you want to, and I'll explain that on the next slide, plug in everything you want to observe. And it's basically like a start and stop time. So every time we'd shadow the nurse, we'd go up with our tablet. Okay, she's administering medication now. I'd click the category. It starts the time clock. She's finished administering her medication. I would stop the time clock and it would all get registered into a data collection sheet. And you could export that on Excel. It was very easy to handle. Some of the limitations, obviously when the nurses know they're being followed, sometimes the behavior changes, but we couldn't really change that. And also we did not take into account multitasking into this project, but we all know nurses multitask all the time. So this is how we categorized all the activities. So we had direct care activities. So this is any activity that's performed through direct interaction with the patient. We had indirect care activities, which was anything performed without direct interaction with the patient, but is about the patient and or on their behalf. And the third one was non-value added activities. So that's any activity that doesn't contribute to the care of the patient. So that's a lot of administrative stuff or hunting and gathering for your supplies, waiting delays, stuff like that. This is just an example. We were basically able to put everything into pie charts and charts. So out of the 226 hours of total activities observed, 31% was actually direct care, 52% was indirect care, and 17% was non-value added, which is quite a bit. So we're only spending 31% of our time in direct interaction with the patient. And then there's just the breakdown of the total hours observed by job titles. So we did observe the nurse for 132 hours, the LPN for about 58 hours, and again, the PAB, sorry, that's French, the patient care attendant for 36.4 hours. I'm not going to go into this too much, but this is just to further show you how much further we can break down the information. So for the nurse specifically, for total direct activities, we observed 40 hours of that. The majority of that time is spent doing an actual bedside procedure. And I'll show you the next slide. We can actually break down what type of bedside procedure they're doing. 14% was administration of medication, 11% was communicating with patients, so it would all break it down. Same with the total indirect. So someone mentioned documentation. Yes, it does take up a lot of time. And I'm very embarrassed to say that we still are a paper-based where we are, and we'll get into that in a little bit. But 30% of the indirect time was spent documenting. That's a large chunk of time to be spent documenting. Nursing report was actually taking a lot of time. So we wanted to focus on that. Communicating with the care team. So that's all your interactions with all your different care teams, your physicians and so forth. And then it just further breaks it down. Again, it can further break down. So we were able to identify the bedside procedures that were being done. The majority was related to an IV, inserting an IV, removing an IV, fixing the dressing or whatnot, drawing bloods and so forth. Same with documentation. We were able to break down what they were documenting, where they were spending the most time documenting. And they were spending the most time documenting their daily assessment, again, for paper chart. So this was kind of the common themes that we took from a bunch of all those graphs and hundreds of data from that Excel sheet. And from the 3 units, there were common themes, and it was very interesting because we were able to share this with other units because we saw common themes. And so it's obviously happening in other units. And so we shared this with a lot of other units so that they don't have to wait for us to come and start this project on their unit, because again, we're 5 facilities. By the time we get to the last unit, it's probably going to be 10 years down the line, and there's no point in waiting. So at least they could see this and they could identify areas in their own unit and where they would want to focus on. So for direct care, the dyad. Historically at the MUHC, we never really had dyads. LPNs were pretty new to us. I mean, they were integrated 10 years ago, but it was very selective where they were integrated, very selective. We did get training, probably not the best training. So when we were observing the nurses functioning in these dyads, we did notice that there were 3 different types of models going on. So not everyone was practicing the same way or what we as an institution had expected them to practice. Some nurses were separating their assignments. So if you were in a dyad with an LPN and you had 8 patients or 10 patients for the day, they were giving 5 to the LPN and they were keeping 5 for themselves. So, there was a lot of concern around this when we started to identify this stuff. And also because of that, the RN did not have a good overview of all her patients. And so when physicians would come ask them, about a particular patient, they say, well, that's not my patient, it's the LPN's patient. And we can't really do that. So I identified a lot of those problems. And again, there was a lot of inefficiencies in the dynamic of the dyad. So we found out that 75 to 90% of the activities performed could have been by the nurse could have actually been delegated to the LPN. So on some units, the RNs felt super overloaded because if they were separating their assignment, they were doing full care for these 5 patients, and they would have to do everything that was outside of the scope of the LPN for the other 5. That's insane. So they were also feeling very overwhelmed and bombarded by this. So having the nurse and the LPN function as a true dyad would really allow the nurse to delegate certain activities, free up their time to function more within the full scope of their practice, and that was one of our goals. Documentation was another huge thing. Again, we were largely paper documentation. We were promised electronic 10 years ago. It never came. Now, finally, we're told we're going to get Epic in 2 years. So our fingers are crossed. We kind of have a dual system where part is electronic, like just vital signs, very, very basic stuff. And we also have the paper chart, which kind of adds another complex layer because it's fragmented documentation. And there was a lot of double documentation because of all the paper forms that we're used to dealing with. For the nursing report, actually, I don't know if I did slide down for the nursing report, it varied between 9% to 30%. So there was a lot of inefficiencies. There was a lot of long, dragged out reports. Some had no structure to it. Searching for supplies was a big thing too. A lot of nurses just spent a lot of time looking for what they needed to do to function in their day. So what are some of the strategies and the next steps? And given the time limitation, I'm only going to focus on a few things that we were able to implement on these units and the priorities they decided to work on. So this is just an example of the identified priorities for the 12th floor unit that we did. Again, we really wanted to individualize it as well, because even though we did see common themes, you still want to make it applicable to that particular unit. So our main goal for the next step was really to show the teams how to change practice and the tools they needed to successfully implement a change practice. So for every unit, we analyzed their data. We would identify their priorities, and this was done with them, with their leadership teams and with the staff, which was really important for them to get engaged. We would then, so after the leadership team identified these priorities, we would brainstorm with the staff. We had a lot of brainstorming sessions, kind of lunch and learns and stuff like that. And because we really wanted to engage them and empower them to generate the solutions. The best solutions I find come from them. They're the end users. They're the ones who are going to be giving the care. We established work groups once we identified the priorities, and this was really done with volunteers. So the nurses, some LPNs, not PBs, some patient care attendants, and some key stakeholders, depending on what we were working on. If we were working on supplies, we need our logistics team on board as well, because they may need to rearrange the nursing cart in terms of where to get your supplies. And to further develop the plans and teach them about PDSA cycles, change management. So we really did this in workshops with the staff nurses and the leadership teams. We kind of gave them a crash course on change management and PDSA cycles and how they could do the changes themselves. And again, this was done in a one-day structured workshop. So this was the MGH 10th floor. This was the thoracic surgical unit. They decided to work on their nursing diet to start. So again, we gave them some control. We let them choose which priorities they wanted to work on, which meant the most to them. This was easy for them to work on because they were new. The LPNs only got integrated a year ago, maybe. So it was fresh in their minds. So kind of nip it in the butt right now to show them what the best practice would be. And even though they were taught, there was key elements that were missing, and I think the key element was simulations. So they were taught theory, and I think that's great. I don't know about your schools, but in our schools, they're not taught to work with LPNs at all. The LPNs are taught to work with nurses, but not the other way around. So I think that's a big gap for us in terms of the colleges for us. So it was really the simulation. So they all understood the theory, but putting it into practice, they just didn't know how to put it into practice to make it actually work. So we did create a 4-hour workshop with a lot of simulations. We created a lot of tools, which included tip sheets, diagrams, reference tools, communication games. And it was really with the intent to clarify the role of the nurse and the LPN. So there are different scopes of practices, enhance their communication, because that was key, how to communicate. And it's really like a constant communication throughout the day that they were just not used to doing. We also developed something to help them structure their beginning day, do the rounds together was kind of one of our intents, and so forth. And so red flags of patient population was another thing for thoracic surgery in particular, because they have a lot of nuances when they know their patients are going to go sour. And some of the LPNs, we had some very candid discussions with them. Some of them said, well, we don't know. So if I don't know that particular little nuance for the thoracic surgery to tell the nurse that something's going on, I won't tell them because I don't know what's wrong or something's going bad. So we created these little red flags for that particular patient population on what they should be aware of so that they know when to alert the nurse. And this is also useful for new nurses when they come in as well. So we did a pre and post survey for this particular unit. And the results were 100% understood how the dyad functions versus only 40% pre. 100% felt like they have a more global picture of all their patients versus 40% pre. 88% felt that the diet allowed for a more focused care versus 40%. 75% felt the responsibilities and tasks were adequately divided to ensure an efficient workflow versus 20% pre. And 75% believe that working in a diet allows for tasks and responsibilities to be done in a timely manner versus 60%. So we were pretty happy with these results that they now better understand. And actually, I spoke to a patient just to try to get their feedback. And they actually enjoyed having the first round where both of them come in. They felt like more eyes are on them and more people are caring for me. And so from a patient perspective, they actually appreciated the dyad, which was a misconception of the nurse, that they felt it was too overwhelming to have two people come into the room at the same time for that particular patient. So that was pretty interesting. For the neurological hospital, they decided to focus on their nursing report. So what they were doing in the beginning, they were actually using it as a teaching session as well. So they would do a giant group report, but would also incorporate teaching, which kind of made it go longer and longer and longer and longer. We also found that it was causing a great source of anxiety for some of the junior nurses because they felt questioned, targeted, called out in front of the group for particular things they were not identifying with their patient assignment for that day or not questioning. And even in some post interviews we did of some of the staff that were leaving, that was even stated specifically as why they left the unit, was because of that morning report. So we completely restructured it. We removed the group report. They do their teaching in a separate environment. We provided a more structured report for them to follow, like what is essential to give in a nursing report so we don't ramble on. We save some time. And it was more of a one-on-one. So with this, each nurse every single day saved 15 minutes of their time, which is the savings of 75 to 90 minutes of daily nursing time that now can be better spent. We had a lot of positive feedback from the staff. They were happy to be starting their shift earlier to see their patients. They felt they were able to save time. And they were able to ask questions during report to clarify, which results in a safer transfer of care and improved quality of care. Whereas before in the group, a lot of them were too afraid to ask any questions to clarify because they felt they were going to be called out. The same unit decided also to work on documentation. For us, it was really to clarify the expectations of documentation. Again, because we were paper, they would chart the same thing in like 5 different areas because they didn't really know where it should go. And they were worried someone was going to miss the information, so they would spend time charting it everywhere. So really to clarify for them where you need to chart it and what you need to chart. We did a 5S. I don't know if you know what that is, but it's really sort, set, shine, standardize, and sustain. So we really cleaned up our forms. We found a lot of outdated forms, duplicated forms, same info on 2 different forms, which basically, as an organization, we're asking them to double document. So we really had to clean up our forms on our end. And we did a lot of in-services in terms of we do charting by exception. So what does that actually mean? Because I'm already at red. Because some people felt, they need to chart, whereas they didn't realize they were already charting something there. You don't need to rechart it here. Some of the results, we decreased double documentation by 8%. I know it doesn't seem like a lot, but it's a start. I think it's a work in progress, and hopefully with electronic, it's going to only get better. We did get a lot of positive feedback from the staff, though. They felt they were able to spend more time with their patients. They're saving time now, now that I know where to document and where. For the MGH 12 floor, so for their project, they decided to do a materials management project. And you can see the pre and post pictures. So we really did a cleanup of their unit. We used, again, the 5S methodology. So we really kind of cleaned up everything, sorted everything, organized everything. We collaborated with logistics for this because initially logistics arranged that cart that you see over there on how they felt they should be scanning the cart. So for a nurse, like a dressing would be here and the other part of the dressing's down there. It just didn't make any sense. So they rearranged it to how we work. And we got a lot of nurses, obviously, because they were part of the work group, they were able to redesign their own cart. So we stocked it as more logistical manner, reorganized the medication room as well. We streamlined a lot of care supplies. So all your feeding care supplies would be in one area instead of having to go to 5 different areas to just get your feeding supplies. And we decluttered the unit. I don't know if you can see that hallway. It's a huge patient safety issue. And if there's an emergency situation, we can't even get the crash cart around the bed. And they've kept it up. Some of the results, and these are only some because I can't share everything. So gathering the feeding supplies, they're able to do it 3 times faster. So 53 seconds versus 18 seconds. I know it doesn't seem like a lot, but it adds up throughout your day. And if you trim off seconds off of everything, you're going to get a lot more time back. They also decided to create admission packages, which saves 84 to 112 minutes per month. And there was a lot of staff appreciation with that. We did a lot of spaghetti diagrams. I'm not sure if you know what a spaghetti diagrams is, but it's really where you kind of trace their steps and where they have to go for particular things. So for those feeding supplies, we realized they had to go to like 5 different places to just get the supplies they needed to start a feeding. Whereas now they just go to one spot and everything is there. Because we're a large organization, large in Canadian style, I guess. So we really wanted to communicate and disseminate this information with the rest of our facilities. So we shared all our information about our concerns about the dyad work group with our MUHC LPN work group. We shared all that time that's spent documenting with our MUHC nursing documentation committee. We presented at nursing executive committee where our associate director of nursing sits as well as our director of nursing sits. We've presented at clinical leadership meetings. Again, we have a lot of our advanced practice nurses there, our educators, our NPs are there as well, nurse practitioners. And we presented in a lot of mission-based meetings. So going more to like the surgical mission and presenting it there. And it was really to inspire them, share strategies, and just create a discussion. So some of the lessons that I learned, so it's important to go back to the basics. So I think multiple small changes can make a difference, and it's kind of like a drop in the water. You got to start somewhere. Learn what is actually going on the units. It was really eye-opening for me, even though I've worked on the units a long time, to see what the nurses are doing on a daily basis and really truly understand their day-to-day workflows. Engaging the staff is super important. And it means so much more when the solutions are actually coming from them. And once they're engaged, buy-in is so much greater. You basically empower them, and they own it, right? They're creating it themselves and they own it. Um, and it's really our job to support them and give them the tools to make it work. Um, Continuous improvement cycles. I think it's important to be open-minded to change. So be ready to change your course if something's not working. It's okay if it's not working. Um, as long as you're open-minded, keeping the staff engaged. They're the end user, so they will really end up deciding. So if your first plan was to implement this and now it's not working, it's okay. Let's see what's not working and let's try again. And again, keeping your staff engaged. The fourth thing was data collection. So data speaks volumes. And I can't say that enough. Showing the staff as well as other stakeholders the data allows them to better understand it and really see the problem more clearly. It also gives you more leverage if you want to make more change at an organizational level. And think sustainability. It's the most challenging, but it's probably the most important. Because if it's not being addressed and discussed through the whole process of change, it's not going to work. And you don't want to have to come back 5 years from now doing the exact same thing you just spent all this time doing. So it's super important to think about it ahead of time. You can integrate it into orientations, in services, mentorships, identify champions on your unit. It's time that we start, working smarter and not harder. So we really have to think of sustainability whenever we make a change. And that's all I had, and my contact information's at the bottom. Any questions? Mhm.
Okay, there we go. First of all, you've made my day. Actually, you've made my whole week. This was a great. It is exactly what we need to do to verify the actual work that's being done. So I had a couple of questions, but I wanted you to know that we love Canada. You are the holy grail for us right now, and thank you.
Thank you.
My second early career, I am the nurse who I am today because I met Ann Dixon, who was a Canadian my senior nurse, who guided me, and I am forever, ever grateful for her. The Canadian nurses absolutely no scope of practice, and you have done more for understanding professional nursing and professional practice than the United States has done. So thank you. Um, how did you verify in the very beginning that your nurses actually knew those items they were assessing?
So we asked them what their thoughts were on the scope of practice. So we did show them what it meant, and so that's only kind of the dimensions, and there's really descriptive indicators in terms of what it actually means more in practice. And so they were
So they actually knew the
they actually
items.
knew
You're
the
clear
items.
they knew
Correct.
the
It
items.
wasn't just that title that you just saw. Yeah.
Got it.
So they were clear on what they were answering.
Okay. The other thing is that, and we can have another dialogue about this, but we used in this country differentiating nursing from direct and indirect. And there were some real issues around that.
Mhm.
And I think I could advise you on how you would have had different scores if you, for instance, had the conversation between and among professionals and physicians. That's called the transfer of knowledge.
Mhm.
That's direct care. That's not indirect. When you make it indirect, it's extra. When you make it direct, it's owned at the direct process.
Mhm.
And I want to comment, absolutely support that the understanding of the difference between the RN and the LVN role is critical. And in this country, you cannot do what you did.
Mhm.
they cannot have independent assignments. And but we don't teach it well enough. But where'd Pam go? Well, she stepped up for a minute, but we're going to change that in St. Mary's School of Nursing, because they're going to walk out of that school knowing the difference between the professional role and the technical role. They're not better than, they're just different than.
Mhm.
But I would be more than happy to talk to you in more detail about how you might rearrange some of those items.
Absolutely. I appreciate that. Thank you.